very welcome here this evening to our November Thoughtful Childbirth webinar. And tonight it's on all things premature. So I hope for those of you who have logged in, you're not about to anytime soon have load shedding. For those of you who will be listening to the recording later, we're sorry that you couldn't join us live tonight, but we are recording it. It will be made available for you to listen to, and we'll tell you more about that later. So for those of you who don't know me, I'm Lynn Bluff. My background is a nursing sister, midwife, childbirth educator. I'm the editor of the Expectant Mother's Guide. And really the thing that's important about me is that I'm passionate about informed choices, evidence-based birth, and knowing your options. And those are really things that actually are very, very close to my heart, that we want people to know what the real facts are out there so that they can come out and have the most amazing birthing and breastfeeding and parenting experiences. Just a big thanks to Jason, Tammy, and Seth behind the scenes who actually helped make this evening all possible, and we really appreciate their time and their input. Also, a huge thank you to our sponsors who tonight are Dis-Chem Baby City and Huggies Nappies. We really do appreciate the participation with us with really important events, because we are then able to accommodate so many more people actually getting the information. In case you don't know us at Baby Talk, we've got a wide range of information that we can offer you to help you through your pregnancy, birth, breastfeeding, and parenting experience. We have the Expectant Mother's Guide. It's an A5 magazine that is a printed magazine. It is also an online on expectantmothersguide.coza, and all of these various platforms are free to access. So just actually try and access as many of them as you actually can. Okay, it's also downloadable as an app, both from Google Play and the App Store. And then we have got the Expectant Mother's Guide Journey app as well. And that gives you access to the Expectant Mother's Guide, but a whole lot more as well. Okay, and this is where you can go and listen to the monthly webinars, and you can book for the future webinars there as well. So if you have, you can't make the full evening, or you've missed out on the previous webinars, please download the Expectant Mother's Guide Journey app, and you will find them at the top under Thoughtful Childbirth free monthly webinars. We also do the tomom.me or the To Mommy digital collated newsletter that actually helps you access evidence-based websites so that you are sure you're reading off really good websites, because we don't want you to go to really bad, outdated, fake news websites. We really want you to have the best available information possible. We also offer consults on birthing options and informed choices. Then we do the free monthly webinars under Thoughtful Childbirth, where we can really aid pregnant mums and dads on their pregnancy and birthing journeys. Okay, our next webinar is going to be in December, Thursday, the 1st of December, and it's going to be looking at going back to work and breastfeeding. January 1, early in the year, the 14th of January, we'll be looking at how to strive for a natural birth. So don't forget to book your space at thoughtfulchildbirth.co.za. Later in the evening, there'll be a feedback form. Tammy will be putting the link into the chat box and you will be able to access the form. Your feedback is really important to us, as well as it will give you the opportunity to receive a certificate of attendance that sometime in the future you'll be able to prove to your child what diligent, expectant parents you were, and you really prepared well for their arrival. Our program for the evening, we're going to be hearing a couple of minutes from Baby City. We're going to just look at prematurity in general, and then we'll be looking at mimicking the womb in the neonatal intensive care unit. We will be stopping for a short tea break around about 8 o'clock or so. And so you don't have to miss a second. We will stop for about 10 minutes so that you can make yourself comfortable, grab something to drink, and we will carry on. We will hear a few minutes from Huggies on all sorts of important issues. We'll be hearing about a Prem family's journey, and then we will be having questions and giveaways near the end of the evening. So really welcome and enjoy the evening, and hope you really found it helpful to you. So from our main sponsor, Dis-Chem Baby City, they are really excited to be part of this occasion of the launch of Prematurity Awareness 2022. And Baby City is immensely proud of the opportunity to play a part in educating the community on the importance of subjects like prematurity, breastfeeding, and skin-to-skin contact for mom and baby at birth and beyond. We hope that the occasion will be one of many of its kind, as new and expectant mothers and fathers journey discovering their unique experience and utilizing this important information about prematurity, breastfeeding, and skin to skin. Mums are with their new baby skin to skin just after birth, and Baby City is with your family heart to heart through every step of the incredible journey that is becoming parents. Okay, so have you all got your perfect birth plan? Okay, does it perhaps read something like this? I want to stay at home as long as possible. Perhaps I want a water birth. I definitely don't want any pain medication. I'd love to have immediate skin to skin as soon as my baby is born. Have my baby put on my chest. Watch my baby go through those really exciting non-instinctive stages, ending in breastfeeding, and as that baby really latches on, perhaps going home the next day. Doesn't it sound just so wonderful? Just what we want, our perfect birth plan. Maybe for some it's in our minds, maybe for others we've actually put pen to paper, but nowhere does it mention a prem labor and prem baby. That only happens to other people, right? And the answer is wrong. Okay, instead of our perfect birth plan, we can rather be confronted with this. This isn't what is part of our perfect birth plan. Okay, and the 17th of November is World Prematurity Day. And so what do we really mean when we look at prematurity? And the fact is that 1 baby in 10 is actually born premature worldwide. So approximately 15 million babies are born preterm each year, accounting for about 1 in 10 of all babies worldwide. So it's certainly something that is far too common. It isn't just happening to somebody else. It often confronts us very close to home. And about 84,000 of these prem births actually occur in South Africa. And that works out to about 1 in 8 babies are actually prem in South Africa. Now, we've got to look at the fact that 10% of the preterm infants born in South Africa do not survive. Despite that, the majority of preterm births occur at healthcare facilities. So we need to acknowledge that not all prem baby journeys end happily. So we want to do our best and strive to have a full-term baby when it is actually within our control. And sometimes it is within our control, and other times it is totally out of our control. So today is the day to learn about prem labor and what it is, how to avoid it, and then if you have a prem baby, most importantly, is how best to look after it, because that really can change everything for this precious little baby that has been born premature. So what actually is premature birth? And a premature baby is one who's born too early, and that is before 37 weeks of pregnancy. Now, pregnancy is actually classed as 40 weeks, and we are saying anything that is born before 37 weeks is actually considered premature. So it's broken down into late preterm birth, when your baby is born between 34 and 36 completed weeks of pregnancy. Your moderately preterm baby, that is born between 32 and 34 weeks. Your very preterm baby, when your baby is born less than 32 weeks of pregnancy. And then your extremely preterm infant, when your baby is born at or before about 25 weeks of pregnancy. And it really is quite amazing to really think about the fact that this baby of 25 weeks, which is really just over halfway, okay, halfway being 20 weeks of pregnancy, your baby at 24, 25 weeks of pregnancy can actually be born. And there's something called viability. And viability is when a baby can actually survive, okay? And it's classed as that 24, 25 week mark is your viability cutoff point. Anything before 24 weeks, your baby is really unlikely to survive. It is just too premature. If we look at 30 years ago, okay, that viability cutoff point was 28 weeks of pregnancy. And so we can see that there have been huge medical advances in the last 30 years within the premature field, okay, that this baby can actually survive earlier than it could have before. Now, if we have a look at what are the risk factors that can lead you to having a prem baby, and this is where we can say, actually, there are some things within our control that we can do or not do that are going to make us at a higher risk or at a lower risk. And the first one is smoking. Okay, smoking definitely does affect your pregnancy, it does affect your baby. And for somebody who is smoking, they are more likely or at higher risk of having a premature baby. Drinking alcohol, again, okay, it increases your risk of having a preterm baby. Pregnancy is only 40 weeks, okay, 9 months. I know when you're pregnant, it feels like a lifetime, but it is such a really short period of time in your life that one can actually stop the smoking, stop drinking the alcohol for that time, to give your baby the best opportunity to be as healthy as they can and mature as they can when they are actually born. No drug use. Okay, vaginal infections are another one that can actually lead you to having a prem baby or prem birth. Okay, so if you have got any vaginal infections, or the next one is urinary tract infections, don't just ignore it, don't just leave it, go and have it sorted and treated. And if you need medication, okay, it is important to take the medication, because otherwise these infections can easily trigger your body into having a prem labor. Stress. Okay, stress releases all sorts of hormones, and hormones play a huge big role in what happens around labor. And so try and stay as calm, as peaceful, in control as possible, and actually decrease the stress. And sometimes that is really, really hard, but actually try and decrease your stress, because it will be better for your baby. And don't we want the best for our baby? If we are obese, okay, again, it puts you at a higher risk of a prem birth. Having pregnancies close together and not spaced apart. Multiples, twins, triplets, and all the rest definitely increase the risk of us having a prem baby. There's only so much room in that uterus, okay, and so it definitely complicates issues and often lands up as a preterm birth. And then pregnancy complications like diabetes, hypertension, placenta previa, where the placenta is very low, lying over the cervix. Okay, those are going to be more out of our control. And, you know, we've just got to accept that sometimes we can't get away from the fact that we are going to land up with a prem labor. A couple of facts, okay, one we've already said, 1 in 10 babies are born prematurely. About 40% are actually born to first-time moms, and up to 50% of women who give birth to prem babies actually have no known risk factors. Okay, so yes, there are some things within our control and others not. So really, really important, make sure you eat a healthy diet, lead a healthy lifestyle during pregnancy, don't smoke, don't drink, exercise, eat well, sleep well, and your body is then in an optimal state, and hence your baby has got this environment to actually grow as optimally as possible. Don't have any drugs and don't take any medication unless your doctor has told you so. Okay, so if you have a headache, don't reach for the box of painkillers first. Okay, use other things for a first line of action, and only take any medication if you absolutely have to, even if it is over-the-counter medication. And when you are needing to take any medication, please make sure that the pharmacy know that you are pregnant. Double check that actually it is safe during pregnancy. And when you get home and you've got the package insert of your medication, please actually read it and make sure it doesn't say contraindicated in pregnancy. If you are HIV positive, then it is very important to take the meds, the antiretrovirals, so you and your baby can be as healthy as possible. When you need to wee, okay, which is, oh my goodness, just so often when you are pregnant, don't hold it in, go to the loo, as the risk of getting a urinary tract infection is then less, okay? If you keep holding it in, you are more susceptible to developing a urinary tract infection, which we said was one of the causes that could trigger a prem labor. Remember to drink good amounts of clean water. That is really, really important too. Also, very important to go for your regular checkups while you're pregnant so that they can pick up any problems early rather than waiting till you and your baby are in danger, particularly from things like high blood pressure in pregnancy. So don't think, oh goodness, I'm not going to waste my time, my energy and my money going to all these checkups. I'm feeling fine. If I don't feel fine, I'll then go for them. By the time you are not feeling fine when you are pregnant, you and your baby could be in serious danger. Okay, so very, very important to go for your regular checkups. You want everything to be fine. You want to be in and out, you know, in a few minutes saying, hey, everything is good, and off you go. But at least if there is a problem, they will pick it up a lot sooner before you and your baby's lives are both in danger. Few signs and symptoms of prem labor: really low backache, sustained for a while, for a long period, contractions, regular, every 10-minute contractions. Okay, there's something regular about it. Don't confuse prem labor with your Braxton Hicks contractions. Your Braxton Hicks contractions are your uterus actually practicing for labor, and so they do practice contractions, and these occur during your pregnancy when your uterus is really, really small. You are not aware of it. As your uterus increases in size, you do become more aware of these Braxton Hicks contractions, but Braxton Hicks contractions don't follow any regular pattern. You'll have one now, and you'll have one later, and sometime again after that. When you are in prem labor, okay, your contractions are going to start coming very, very regularly. Your lower abdominal cramps, like period pain, also for a sustained period of time. Any fluid leaking from the vagina, meaning that your membranes have actually ruptured prematurely. A bloody show, that mucousy discharge. Okay, you go to the loo, you wipe yourself, and there's a bit of blood, a bit of mucus, and that is your mucus plug that has come away from your cervix, tending to say actually something is happening, labor is happening, your cervix could be dilating. However, if you have been for a checkup and they have done a vaginal examination, it could just be from that as well. So don't necessarily panic about that. Okay, just monitor it and see if anything else comes from that. In real lower abdominal pressure, and if you have any or more than one of these, okay, rather go and get it checked out at the clinic or the doctor or the hospital where you're going to have your baby, to see if there are any, if it's something that is significant and needs sorting out. Okay, sometimes they can actually stop prem labor. They knock you out of it, your uterus relaxes, your membranes haven't ruptured, and everything kind of stays there, but on balance and tender hooks and sensitive for a while, but actually they are able to stop prem labor. And other times they actually can't, no matter what you do or anybody else does. Okay, the fact is that you are going to actually continue with your prem labor and have a prem baby. So sometimes there is just no turning back, and we land with in
neonatal intensive care unit, NICU. If there are medical concerns with your baby, your healthcare team may call the neonatal intensive care unit team to attend your birth or assess your baby on the mother-baby care unit. The neonatal intensive care unit, also known as the NICU, is part of London Health Sciences Centre's tertiary care perinatal program. This unit provides care for babies who are born prematurely, who have a low birth weight, and or who are sick or at risk for other reasons. The staff in the NICU consists of a multidisciplinary team of professionals. Team members may include your baby's neonatologist, registered nurses, respiratory therapists, allied health professionals, and students. London Health Sciences Centre is committed to family-centered care. The support of family and friends is important. However, there are limitations on the number of visitors in the NICU in order to prevent the spread of infection to this very vulnerable group of patients. Parents and siblings of the baby are welcome to come to the NICU at any time. An up-to-date immunization record, including the varicella chickenpox vaccine, must be shown before a sibling can visit. The number of visitors is limited to 3 people at a time, and non-siblings must be over the age of 16.
Okay, hopefully that has given you just a little bit of an idea what a neonatal unit actually looks like. It can be a really noisy place, lots of monitors going, lots of beeping, okay, just to introduce you a little bit to that environment. So what does a prem baby look like? Now, a slightly prem baby may look very similar to a normal newborn. It's just a lot smaller, whereas a very prem baby looks very different. Okay, sometimes it can just be so small, it can actually fit snugly into your hand. And that's hard to imagine that you can have this perfectly formed little baby, a real miniature little human, actually being held in your hand. He will look very, very skinny because it's in those last few weeks of pregnancy that he actually puts the fat on during pregnancy. So if he comes out early, he hasn't got these fattened little limbs. His skin might be very fragile and actually pretty see-through, because he's thin, his skin is just so thin. His eyelids might still be fused shut, and he can be very, very hairy. You think, my goodness, have I actually given birth to a baby, or have I given birth to this little monkey? Because he is just covered, his whole body is covered with a soft downy hair, and that is called lanuga. And now all babies actually, while they are developing in utero, have got the soft downy hair. And as they mature, so that hair actually falls off before they generally are born. And obviously, if this baby is born prematurely, we have this very, very hairy little baby. You may be covered with what is called vernix caseosa, and that is a real white, greasy substance. Okay, he looks as though he's plastered with this greasy substance. And this is what is actually looking after your baby's skin. Remember that this baby is living in water for 9 months, and that skin actually needs to be looked after. If you stay in the bath for an hour, you come out all wrinkly. Your baby stays in water for 9 months. It's got to have something to protect its skin. And this vernix towards the end of pregnancy is usually absorbed into the skin. And so a full-term baby has very, very little or none at all, whereas this prem baby can be covered with this very, very white, greasy substance. And an extremely prem baby may actually only weigh 500 grams. Think of a big pat of butter, okay? That's 500 grams, and that's how much your baby can actually weigh. Now for 6, 7, 8, or 9 months, your baby has been with you every minute of every day. You are actually inseparable. The uterus or the womb is where the baby lives and grows till he is born. Now the womb has kept him warm, safe, loved, protected, and fed. All his needs are actually met. And that is where your developing fetus actually belongs. And now that this baby is has been born, we've got to find this new place where new babies actually belong. And this new place is actually on mom's chest. So if you do have a prem baby, as soon as it is stable and they're allowed, make sure you put your baby skin to skin with you. And when we talk about skin to skin, what does this actually mean for a baby? And it means that it's only got a Huggies on, you know, one of those nappies. And we put that nappy on and then the rest of the baby is actually naked. And we put that baby on mom's chest without any clothes on her, so that you actually have that skin to skin situation. You can then wrap your baby to you and then put a shirt or a cover over you, and you've got two hands free and your baby skin to skin. Now, if you haven't heard about skin to skin tonight, we're not going to be talking about it to any great extent, but there is a webinar that we did in June on skin to skin for mom, dad, and baby at birth and beyond. You will find that recording on the Expectant Mother's Guide Journey app. And please, it really is one of the most important webinars you can actually listen to if you don't know too much about skin to skin, because it makes a difference for all babies, and even a bigger difference if your baby is prem. So the majority of prem babies could quite easily land up in the neonatal ICU. It's a completely new world, and this could be your baby's home for the next day, weeks, and in some cases even months. And so sometimes this is the best place for your baby and where your baby actually needs to be. And it can be quite a frightening place in the beginning until you get used to it, but it can be the best place for your baby. And on that note, I am going to hand over to Prof. Velma Libber, and she's going to chat through how to mimic the womb environment in the neonatal ICU for preemies and the neurodevelopmental reasons. Now, for those of you who may not know who Velma Libber is, she's a professor in nursing and midwifery at the Northwest University. To just give you an idea what a legend she is, she's published over 42 peer-reviewed articles, presented at 72 national and 19 international conferences with posters and papers, and a number of professional and parenting articles. She focuses her research in the field of neurodevelopmental supportive care of the preterm infant and leads the implementation of neurodevelopmental supportive care research program. And Velma is the founder and owner of Little Steps, which is a South African premier parenting support organization, which she developed the first South African evidence-based website on prematurity, and provides services such as an online premier parenting education program. She's the author of Prematurity, Adjusting Your Dream, but most of all, she's passionate about returning the parenting role to parents of newborns and prem babies. So we are going to hear from her. Velma, welcome. We are really just so excited to have you join us tonight and to actually give people listening here to you tonight the best possible person to educate them on prematurity and how to look after their little prem baby.
Thank you so much, Lynn, and thanks for that nice introduction. I do appreciate. Yeah, at the end of the day, the only thing that it's important is that I love parents and I love premature babies. And I really hope that this evening's talk will be worth your while, that you may learn something new. I also see some people in the audience that are some of my colleagues who know about prematurity. So I hope also for you, there will be at least one thing that is new that you haven't known before. So yes, we decided to talk about mimicking the womb environment. And that is so important because it doesn't help that this baby is born and they survive, but they don't have this optimal development. So for that specific reason, I'm going to take one step back, and Len already talked about this a little bit, but I want to expand a bit about womb environment. What is it like? So for those of you that are pregnant on the call, I know some of you are not, or planning, or have been very long ago, but just think a little bit, when you hear that you are pregnant, where do you go with your hands? I just want you to think about that for a moment. usually it goes onto your tummy. And there's a very important reason for that, because the baby, when it is made, it has this natural withdrawal reflex. It wants to protect itself against anything that may be potentially harmful. So when mom puts her hands on the baby, on her abdomen, then that baby will move towards that touch, because now the baby learned that touch is positive, it's good. And that unfortunately is something that can get some damage when the baby is in the ICU for an extended period of time. Now, this touch sensory system develops at about 8 weeks of pregnancy already. So sometimes that's even before mom really realizes that she is pregnant. Now, touch includes that physical touch, the tactile stimulation, we call it. It also includes pain. So it's different sensations that the baby will experience when we talk about touch. It also includes temperature. And if we have a baby that develops a cleft lip or palate, that also develops at about 8 weeks of pregnancy. So just to give you an indication and an idea how these things fit into each other. And that is why your care provider will tell you, even when you plan to fall pregnant, it's important to drink folic acid, because that prevents these kind of abnormalities in the baby. Now, the next system to develop is the movement system. And this is important because the baby is moving around in the womb, but they also need to turn around so that the head is to the bottom of the mom's body, so that the baby can be born in the most safe environment in the safest way. That also developed by about 8 weeks of pregnancy. And then another symptom or another sensory system that develops is then taste. Now, what's interesting about taste is the baby know what mom had for lunch and for supper and for snacks in between and everything. So if you have a preference for chocolate or coffee during your pregnancy, and you smell that and you taste that, that smell and taste molecules will be absorbed through the nose and the mouth, and it will go into the mucous membrane. That will then be absorbed into your bloodstream, and it will move towards the placenta, and it will cross the placenta and go into the amniotic fluid, which is the fluid in which the baby is then surrounded. And the baby then drinks up to 760 ml of amniotic fluid per day. Again, this is very important because the baby drinks almost continuously. They don't drink only every 3 hours. But apart from that, they learn taste and smells which mom had when she was pregnant. So if you're a chocoholic, then sadly it comes from pregnancy. You didn't learn that afterwards. So you can blame it on your mother's pregnancy. So it's very important. We're going to use taste and smell to recreate the womb environment once the baby is born. Then moving on to about 24 weeks, we find that the sound system develops, so the hearing. So by about 24 weeks, the cochlea is there, it's nicely developed, so all the structures, the anatomy is there for the baby to hear. But that organization of hearing may not be well organized. So the baby can get very overstimulated with all the sensory systems, but especially with the sound system. Now, what's important here to remember is the sequence in which the sensory systems develop. And as you'll see on the slide, and as you've heard me say it as well, it is movement, taste, smell, sound, and then only vision comes. But if a baby is born premature, then vision is stimulated before sound, and that can create some challenges for us. So just to hop back to sound, if we think about the sound that developed and that the baby is exposed to in utero, then you will find that it sounds quite different than normal language and normal sound. So to give you an idea, I want you there in front of your computer to say on the count of 3, say with me, good evening, it's a lovely evening. So are you ready? 1, 2, 3. Good evening, it's a lovely evening. Now I would like you to cover your ears with your fingers, and we're going to repeat that. Okay? So cover your ears. 1, 2, 3. Good evening. It's a lovely evening. Now I want you to think about that for a moment. How did it sound the second time around? Did it sound the same than the first time? I assume not. And what we usually find is that when you cover your ears, it's a much more muffled sound. It's a softer sound. Automatically, you'll also speak softer. which you would not have realized now, but when you do it again with your significant other or with your other children or so, you will realize that once you close your ears, then you actually talk a little bit softer. Now, this is what the baby hear in utero, in the womb. They hear the softer, muffled kind of sounds, almost like it's underwater, because the baby is submerged in water. Also, the baby hear mom's heartbeat. They hear that sounds of the tummy moving, that gurgling sounds. They hear the blood, that rush of the blood through the veins. So it's also not quiet in the womb. There is sounds, but it's a different kind of sound. It's not this loud sounds that we hear when we are born. And often when a baby is born, or when the baby is in the postnatal ward or in the cesarean section theatre, that's quite bright and it's quite loud. And all of that can be very overstimulating for this baby, especially the premature baby, who cannot regulate the sounds that they get. It's just too much for them and they can get overstimulated. Now, after the sound then will be the vision that develops. So the baby's irises can't constrict before 6 months of pregnancy. So the baby will, when you shine a light in the baby's eyes, they cannot close their eyes. They cannot shut the light out. And that can be quite problematic. Now we see in the ICU, especially that very prem babies, which Lynn spoke about, that extremely preterm babies and the very preterm babies, when we expose them to sounds and bright lights, then what they will do is they will try and regulate their own body. So what happens is basically they get not enough oxygen going to the brain, like when you feel you want to faint, and then they send more oxygen to the brain, and they do that with sending more blood to the brain because the blood is the carrier of oxygen. So now there's an extra volume of blood that's going to the brain, but that little capillaries, that little veins in the brain are too thin and too fragile. They can't take on this big volume of blood that goes to the brain. And then that causes these veins to burst, and the babies can develop a brain bleed. So if you hear then that a baby was very tiny and they develop a brain bleed as a result of loud noises, bright lights, things like that, then that's actually true. It can happen because that whole brain structure is so thin and so fragile at this stage, and we want to protect it. And that's why we want to mimic the womb environment when we have our babies in the ICU. So the ICU is really the best place for the baby to be, but it's not always the most conducive place. So what can we as parents and healthcare professionals do to make that environment better? Maybe just to also add on to the explanation is you would have realized, if you are familiar with puppies and cats when they are born, their eyes are fused shut for at least 10 to 14 days. And only then does the eyes open. Now, this is significant because when the eyes are shut and the baby don't have that, or the baby cat or dog don't have that visual stimulation, they need to trust on hearing and smell. And they need this in the wild because that's what they need for survival, to find food. And the same thing happens in human babies. If they are exposed to visual stimulation before the hearing and the smell is well developed, what happens then is that the smell and the sound will just stop developing or not develop optimally because now the vision is there to help out. But in the long term, that can lead to different kinds of hearing problems, intonation problems, learning difficulties, and things like that. So it's very important that we try and protect this sequence that we had in the womb. Now, throughout the pregnancy, the brain develops also when we are born and even till we are in old age. Now, just to show you how this brain develops, in previous decades, we thought that babies can't hear, they can't think, they don't feel pain, they can't see when they are in the womb. But now we actually know that they do. So you can see in the pictures here, this is the baby's brain at 20 weeks, which is about 5 months of pregnancy. And you can see the brain surface is quite smooth, but all the structures of the brain is there. But this tells us there's a lot of development that happened, but not a lot of cognitive thinking development. So now we get to 31 weeks. So that would be that almost a moderate preterm baby. So they can do quite okay if they are born. They need oxygen and a little bit of help, but their survival rate's not bad. But you can see if you look at the surface of the brain here, there's a lot of grooves that you can see. So the brain is starting to fold in on itself. So it tells us there's a lot of thinking, a lot of neurological development that happened already, and that need to be stored somewhere. And then you can see at 40 weeks, the size of the brain, it quadruples, it grows 4 times in size. And you can see all those large amount of grooves. Now, the reason why I'm showing you this picture and how this develops is just to understand that our premature baby or our baby, when they're in the womb, then this development happens in the womb environment. So the baby gets the right kind of noise or sound stimulation, the right kind of smell, the right kind of visual stimulation. Everything is just perfect for this brain to develop optimally in most of the cases, except where we may have a congenital abnormality. Now, if this baby is born premature, they're born usually somewhere after 31 weeks. And you can see how much of that development of the brain should still take place between 31 and 40 weeks. Now, the challenge is, if we had the right kind of touch when the baby was in the womb, and we put the baby now in the ICU, where we prick the baby often, where we have bright lights, where we put tubes down their noses, and we do all of these bad things to the baby, then they start to learn that touch is a negative experience. So they react negatively towards touch because they can't discriminate on this is touch that we do in order to save their lives. They just know touch is not good. If we put them in an incubator that is noisy or in a blanket that's not nice and soft, then they get this input 24 hours of a day that tells them that everything I'm lying on is bad, it's hard, it's not nice. And they learn that my environment is not friendly and supporting. So that is now the thing that we are challenged with. We want the baby in the ICU. It's the best place for them to be because we can help them to survive. However, it may not be the best place for their development. So how do we manage this? So I've developed some best practice guidelines, and you can find them and actually download them from the Little Steps website under the resources page if you want to go into more detail. But it's not an academic lecture, so I'm not going to go into much detail. I just want to use it as a bit of a structure. So we have the environment. So that is the ICU environment. So with the doors and the lights and the different babies that's in there and everything that happens there. So that's the macro environment. And then we have the baby's environment, the mini micro environment. So that includes how we position the baby, how we handle the baby, our individualized care, how we teach the baby to self-regulate and support self-regulation. It includes feeding and it includes pain management, because remember, we do a lot of painful things in the ICU. Then there's also a section on the family. So this is just to remember or to remind the hospital and the healthcare professionals that the family, although this is a traumatic birth and it's not the environment that we wanted, it's not that perfect birth, the water birth at home and all those kind of things, the family remains the center of this whole story. The family is very important in the life of the baby. And then for that reason, we need staff education, and we need a whole multidisciplinary team, and all of them need to know the same things. So it's a nice color-coded document. So for those of you that like reading, if you do end up with a baby in ICU, what's nice about it, it tells us what is the latest evidence. What should it be like in the ICU? And then it gives you where the evidence comes from and so on. But at the very end of each of the guidelines, it tells you, how can I get that kind of environment for my baby? What can I do? And I want to share a bit of that. Now, the first one that we look at is that big environment, the ICU environment. Now, we can't always make it nice and dark and similar to the womb. You've seen in the video that Len has shown, it's bright, it's noisy, people talk, they move stuff around. So it's not this nice, calm and friendly womb-like environment, but we can make a womb-like environment for each baby. So in this picture, for example, we use a nest. So the nest is similar to the womb, that nice, snug, fitting environment in which the baby is, so that it can help them to bring their hands to the midline, that they can calm themselves down. It helps them to conserve energy. It even helps them to keep their temperature better, because now there's less of the body surface that's exposed to air. So now they can control their temperature a little bit better. And you can do this in skin to skin, but if mom and dad can't be there, you can also put the baby like this in their crib or in the incubator. And then here we just used a blanket. So it's a nice blanket that we folded and we've put it over the baby so that they are in a nice covered environment where they are safe and protected from the additional light. So I'd like you to look at this picture and then tell me if you, or just think for yourself, do you see a white background or white stripes? So if you see white stripes, just grade yourself. Then if you see black squares, you can raise your other hand. Now I would like to know who is seeing gray dots in between the squares. So if you're seeing gray dots, you can put up your hand. Right. So if you see gray dots, you need to go to the ophthalmologist. Not really. This is a visual perception. So it looks like they are gray dots, but there are none. So that is what happened, especially with a premature baby. Now you are an adult, so you can control this. You can see that there's actually gray dots in between, and you know it shouldn't be there. And if this is actually making you a little bit nauseous and you want to close your eyes and look away, you can actually do that. But our premature baby, remember, the visual system is not well developed. So the premature baby can't look away. They can't turn their head around. They don't have the muscle strength. So if we present them with a visual stimulation that's too much for their system, they can very easily get very overstimulated. So this is the ICU environment, bright lights, noisy, come in from the outside or the overhead lights. Usually there's terrible fluorescent lights. So this is not what we want. And a lot of our ICUs look like this. This is what we want. We want a softer environment, dimmed lights, a blanket or a cover over the incubator. And if you are there as a parent, then you do skin to skin care and you throw a blanket over yourself and the baby, because then you create this womb-like environment for the baby. Then on the noise part, it's very noisy in the ICU. It can be very noisy. Now, what we need for a baby to be able to sleep is less than 50 decibels. In order for them to hear properly and discriminate tones and so on, it's even less than 35 decibels. Now there you can see just the incubator running, that motor running is 58 decibels. When we close the incubator with that little portholes there, people tend to just push them close and then they go "Gok," and then that sound is very loud for the baby. It's 100 decibels. And then other babies crying. Have you ever seen that if there's babies together in a space and one starts crying, then it's not long, then all the others follow. Now, it can be because of sympathy crying, but most of the time it's because it's hurtful. It actually hurts the ears because it's 80 decibels. It's quite a loud noise. And you can think for yourself, if you've been exposed to baby crying in an airplane, for example, for quite some period of time, it's quite annoying and it can really be painful. And then if we talk around the baby and we don't talk a little bit softer, because remember, this baby should have been in the womb. It's a little bit different for the full-term baby. So all of these things that we do create sounds and noise for the baby. So we can tone down on that kind of noise and stuff. And again, we can do skin to skin care and that can actually solve the problem. So now we move into the baby space. Then we want to position the baby in an environment that looks like the womb. So here you can see a little baby in a nest, once again, with a cuddle blanket. So when we talk about smell and we talk about bonding in mum and baby, then we take a blanket, a cuddle blanket, mom's nightie from the previous evening that she slept with, and you put that with the baby in the bed. And then the baby will smell that. That will calm the baby down. It will help with breast milk production for the mum, but for the baby, it will also release some hormones and make them acceptable or receptible for breastfeeding because they smell mum. And remember, mum and the amniotic fluid all smells like breast milk. Again, that's for the baby's survival. So what they had in the womb, they're familiar with, and we can then use that again after birth to make sure that that connection is there, the bonding connection, the breastfeeding connection. But putting the baby then in an environment or in a position that is similar to the womb is very important. So we use nesting. Nesting is a nice, snug, fitting environment. And you can even use it for your full-term baby up to about 3 months after birth, where they are nicely curled up, but not restricted. So they need to be able to move, test their boundaries, feel the boundaries, and that must support them to come back to this flexed and midline position. So we want that flexion and the midline again, because that is what the baby needed for development. So here's a few pictures on flexion and midline. You can see if we work with the baby, we bring the hands together, we bring the knees together, we tuck the baby in a little bit, not too much though, then the baby will be splitting up. We can put the baby in prone on the tummy so that will also help with breathing, because tummy lying helps them to breathe quite a lot better when they are in the ICU. So that's good for them to do. But when we send them home, we want them to lie on their backs. And that has to do with how the baby swallow and where's the windpipe and where's the food pipe. But I'm not going to go into that now. But all of these pictures you can see, you can actually imagine the baby back in the womb, nicely curled up, hands together, feet together, and everything is just nice and snug. If we handle the baby, it's also important that we do things that's good for the baby. So here you can see mom and baby in skin to skin, and you can see that little person with eye contact. Now this was a 28-week baby, so born very early at less than a kilogram. Mom couldn't breastfeed due to a lot of medication that she had to use for high blood pressure to get that under control. So she had to go for formula. Now these days we know we can rather go for expressed breast milk or donor milk that we can get from other mums, or a donor milk bank. But what's important here is she gets skin to skin as often as possible. And this builds the baby's brain. It builds the neurological pathways in the brain. We don't expect a baby this tiny to make good eye contact with a mum. But because of all this skin to skin, she released the hormones that necessary, the baby released the hormones, and that bonding took place, that glue that we need between a mum and a baby. Okay, and then it's important to individualize care. So we want to see where's the baby in their development. I'm also not going to go into detail in this, but you'll see if the baby's very tiny, then they need ICU care. We need to leave them alone. When they're between 32 and 35 weeks, they're actually okay-ish, but they need some additional support. So we need to understand that and provide that to them. And then they're ready to go home. They're like puppies. They eat and they sleep and they poop, and that's all that they do. So if we understand where the baby is in their development, then we can do individualized care. So if this baby isn't turning in, we want limited touch, dark environment, not bothering the baby. But when the baby is in reciprocity, then we can start talking to the baby and do more kinds of interaction and so on. So that's also just important to keep in mind. So here's an explanation or a demo on how the baby then react to stimulation. So mom had a toy or granny and the baby yawned. So she thought, oh, he's probably just waking up. Then she continued with this toy and the baby said, ooh, this is too much. And the hand is coming up trying to get this toy away, which is too much stimulation. Remember, head contact. So now with the eyes, he's trying to talk. The eyes look away, the mouth goes to ooh, and the hand goes out. We call it finger splaying. She missed that. And the baby showed a stop sign together with the other sign. So this is a real stress sign telling us things are too much. Please go away. And then if we miss all of these signs, we get to a crying baby using lots of energy and then don't grow so well because we miss the baby's individualized cues. So we want to change the environment that we do not see this kind of stress in the babies. So here you can see a stressed baby. So what do? We put our hands on the baby, and you can, together with me, just take your hands, you can cross them, put them on your shoulders, exhale, you make your hands heavy. Now that heaviness is similar to what dad's hands usually feel because they're big and heavy. But this is what the womb feels like as well. So whenever you hold or touch your baby, put your hands on the baby, relax totally and exhale. And that is the kind of pressure that is similar to what the baby had in the womb. And that's what we want to do. And then we want to provide the baby with opportunities of self-regulation, things to suck on. So here you can see a stressed baby. So that is a stop sign in the baby. You can see that fingers playing. And we want to reposition the baby, get them back to that flexed fetal position. Get the hands so that they can go to the midline, because hands in the midline and sucking is two techniques that the baby uses to calm themselves down. So easy way to do that is just turning your baby on his side. And that will provide the baby with a womb-like environment without having fancy things that you're going to use. On feeding, I'm not going to go into too much detail, but there is a nice chart on how do I go from a baby that can't feed on the breast to a baby that's fully breastfed. So we use this very nice chart to evaluate the baby as we go along. So again, we individualize the care, do what's right for that baby at that time. And then we also want to do pain management in these babies. Now we do a lot of painful things. So again, you can do skin to skin care to manage the pain. So I want to show you a short video clip on the skin to skin care. So let's just see.
When babies need most effective, breastfeeding.
Okay, so mommy is then breastfeeding, and while she's breastfeeding, and because she's breastfeeding, you can use this for your full-term babies as well when they go for immunizations. The breastfeeding and the skin to skin releases endorphins, and the endorphins make the mum feel good, and they block the pain in the baby, and that pain blocking is as good as morphine. So have a look. You can see how the painful heel prick is being done on the baby, and how the baby just is not bothered because he's breastfeeding. So let's have a quick look.
Breastfeeding can provide much more than nourishment to babies. It can also help reduce their pain and distress from blood tests. As you can see in this video, the nurse pricks the baby's heel for the blood sample while the baby is breastfeeding. As a mother, you can help by holding and breastfeeding your baby while the blood sample is being taken. In order for breastfeeding to have a maximum effect, it should be started about 5 minutes before the blood test. Ask your nurse or doctors about breastfeeding during blood tests or other needles, as well as other ways you can help babies during painful procedures.
Okay, so a wonderful technique which we can use for the babies in ICU, but also at birth when they need to get a vitamin K shot, or we need to do other kinds of tests, or when we are doing immunizations for our babies. And then just to wrap it up, the family, like I said, is very important, and they should be included in the ICU because the family was there when the mom was pregnant. So we should continue with that. And here you can see a sibling, an older sibling with dad, and there is one of twins. She's also the baby that is the model in my book, the storyline. So here you can see dad is doing skin to skin care for a sick baby that's on a ventilator, but the sibling is also visiting in the ICU. Here's a mum that was, the mum herself was in ICU, and the nurses have put this baby in skin to skin. And that actually helped the mum to survive, because she woke up for a moment, she realized, oh, it's my baby on my skin, I need to fight for this baby. And then she went into theater. She thought she was just after the cesarean section. And the staff actually thought this mum will not live. But because of this baby in skin to skin, it just triggered something in the mum and that will to live. So even if the mum is very ill, mum and baby should be kept together as far as possible. And then to get those hormones going, to get an environment that's similar to the ICU, to the womb, we also need to look after parents. So we need to provide them with an environment that's good for them, somewhere where they can just chill and relax a little bit and recharge their batteries. So For family education, if you end up to have a premature baby, you can visit the Little Steps website. We also have an online parenting app that you can learn a lot about these things more in detail than that I have shared with. Or you can, if you're a book reader, you can read the book Prematurity Adjusting Your Dream. It's also available on the website. So the message is there's help available, there's information available. Please use it when you get into that situation. Because at the end of the day, we want healthy families, even if you had to go the ICU journey. So here you can see the twins, Gemma and Nicola, 720 and 880 grams, and they were 27 weeks. And here you can see them on their 18th birthday with, of course, their little sister, Chrissy, which is now a beautiful young woman. And this is what we want to do. We want to help families to get to this point that this is an optimal journey. And it's hard, it's really hard, but it's also very special. And it's important that you can capture those special moments and that you can take that on your journey. So I hope there was some nice and new information for you and some things that you can use in full-term or preterm babies. But most of all, I hope that you will feel empowered and that you will know what to ask and where to ask if you get into the situation where you may end up with a premature baby. Thanks, Lynn. Handing over to you.
Wonderful. Thanks, Velma. And I'm sure everybody is transfixed listening to you because it is just such amazing information. So we really do appreciate you being with us this evening. We're just going to hear a couple of minutes from Huggies and some messages that they have got for you.
Well, that feels pretty soft, right? It's called a pillow. We're Huggies, and we put hundreds of pillows inside this nappy so it's absorbent and soft on your sensitive skin. When Mom makes that face, that's your cue to laugh. She's such a comedian. Huggies, we got you, baby. Well, that.
Okay, now Huggies have a website, huggies.coza, and they would really love you all to register on it. And it's a win-win situation. Okay, there are all sorts of Huggies that you can win by registering. So do go to huggies.co.za, registers on the top right-hand corner, and that'll give you access to an enormous amount of information as well. Okay, and they would like everybody to register indeed.
They look so fluffy up there, don't they? Those pillows in the sky are called clouds. Actual clouds are hard to touch. But we're Huggies, and we can help you feel them with our new pants. The Cloud Soft waistband here is super soft on your tummy here. Huggies, we got you, baby. They look so...
Okay. Not only do Huggies really just concentrate on nappies, but they're actually interested in your relationship with the baby as well. And this is what we call the dance of the nappy, and how babies are connected at birth and how they communicate intimately with you. If you mention nappy changing time, what do you envisage? Oh, this unpleasant chore, gas mask and tongs at this distance, or not my turn. This time it's all yours. I'm now covered in pee and poo. Or should we rather view it as a time to connect? That nappy changing time is a really, really special time that we spend with our baby. And let's have a look at the dance of the nappy.
We've got a really standard everyday occurrence here. In fact, lots of time of day occurrence here. What it shows is the complex, beautiful dance that goes on, even in this most common of situations. Keep in mind, this is a baby who's just over a month old. and his head's turned away. And she's doing this thing that's uncomfortable. She's now exposing him to cold air. And as soon as this starts to happen, look what he does. He turns around to find her face. And he has this really coordinated head movement, although he has to do it slowly. He comes round, and when he finds her face, he stops. So it's goal-directed action. The goal is to find Mama. And he holds her gaze. He holds her gaze. He looks away just for a second, but when he has to quit moving, he's right back there, tied in to her gaze. And now he's starting to smile. And she's starting to smile as well. So she looks away and he keeps his eyes. He's smiling. Right. Can a baby do that at 5 weeks old? Can a baby smile like that? Where's that wind? Lots of us would say, no, it's just wind. It's not meaningful. If you ask lots of mothers, they would tell you that that exchange is meaningful. That the baby smiling is saying, I'm with you, I'm connected, I'm enjoying this. But cultures will teach you, is this wind, is this not, how to interpret this smile. How you interpret it is really important, because if you think it's wind, you don't smile back. If you think the baby's engaging with you, you smile back. And that's where brain development starts, on the basis of the kind of response that you're seeing. This baby's eyes are bright. Mom is totally focused on it. This is
okay, isn't that absolutely something that's incredible to see? And Velma spoke about it, that eye to eye contact, that connection between mom and baby is just phenomenal and builds brain development. So hopefully that has given you a different way to view nappy changing. I'm now going to hand over to Catherine Woodray, and she's going to tell you about their Prem family's journey that they went through with little Emma. Great. Good evening, Catherine.
Hi, good evening. I'm just figuring out sharing my screen.
Okay, down at the bottom. And just to let you know that Catherine in her own right is a medical doctor, and so she can talk about it at all sorts of levels. Thanks, Catherine. Over to you. We can see you and we can hear you.
Thanks so much, Lynn. Right, so yeah, thank you for the introduction. My name is Catherine, and together with my husband Graham, we became parents to little Emma, pictured here 7 weeks ago yesterday. Obviously, a Prem journey is not something that anyone wishes for themselves, so I'm just going to talk a little bit about it. We're so grateful to be home with Emma. And yeah, I'm just going to walk you through our little story. So this was my first pregnancy, and it was all going well until 20 weeks of pregnancy. And at my detail scan, the fetal medicine specialist noted, and the only reason I was at a fetal medicine specialist is because it's Joburg, and that's what everyone does. But she noticed some cervical shortening. And so I was admitted for an emergency procedure called a cerclage, which is a stitch in the cervix to prevent any further dilatation and to prevent preterm delivery. And I was put on bed rest, and I was put on high-dose progesterone, and I was incredibly compliant, so much so that I became massively insulin resistant as I lost muscle bulk, and I was diagnosed with gestational diabetes at 24 weeks, for which I ended up requiring insulin to manage my sugars. And once we got to 35 weeks, we were expecting a preterm delivery from the time that I was admitted for the cerclage. And we were just hoping and praying that we could hang on as long as possible. And it was a miracle that we made it to 35 weeks. But at 35 weeks, there was an indication for delivery. There were placental issues. And because it was too early for an induction of labor, I had an urgent cesarean section delivery at 35 weeks. So because I knew that I was at risk of a possible premature birth, we did everything we could to prepare. So we attended online antenatal classes, and those were really helpful in helping us visualize ourselves in in the space of possibly laboring or possibly having a cesarean delivery, and getting up to date with the importance of breastfeeding, and just being re-reminded. I did know I spent a lot of time in medical school being taught about kangaroo mother care, but also just being re-reminded about kangaroo mother care. Mentally, I tried to do a lot of preparation and just get myself in the headspace that I might have to be a mother to a premature baby, and that my journey would look different to the friends around me who are all having babies, and many of whom have had healthy babies and had everything that you would wish for pregnancy and delivery. And then I also was lent a copy by Lynn of Professor Libber's book, and I found it incredibly insightful. Parts of it were hard to read as I was preparing for a possible preterm birth, just, you know, reading about everything that can go wrong, and prematurity is never optimal. And so, it was hard, but it also really helped me get in the right headspace, and it helped me acquire a lot of knowledge. And so, the delivery was everything that is opposite to what Lynn was mentioning in a birthing plan. I had hoped to have a normal vaginal birth. I had hoped to do immediate skin to skin. I'd hoped to watch my baby go through the 9 instinctive stages. But as you can see, she was wrapped up in a blanket. At birth, she had some respiratory distress, so everyone was keen to get her to NICU. And so I hardly saw her. It was a cesarean delivery. In the NICU, she required non-invasive ventilation. So that means that attached to her nose, she had some pipes that were hooked up to a machine that can give various kinds of respiratory support. And she started with non-invasive ventilation, and with intense to less intense amounts of pressure and oxygen that she received. And we were very lucky that she weaned steadily. But you can see in the initial picture, you can see the nasal apparatus, which was used for breathing. On the first day, I was day 0 post-op, so I wasn't allowed out of bed. And so you can see Graham's hand in the picture. That's a picture that he took to send to me. And he was able to be with her during NICU visiting hours and to bond with her. But unfortunately, I wasn't allowed out of bed till 5 a.m. the next day, at which point you can imagine I just got up out of bed, and I haven't stopped since. After those 3.5 months in bed, I'm very happy to be up. So in the NICU, you can see it was very bright, probably too bright, and it was very noisy, but we did everything we could to be great parents to little Emma. We, at every opportunity, asked the sisters to help her get into skin to skin with us. We managed, even though she was on biphasic and then on CPAP, to have her skin to skin. And everything that we were taught about skin to skin, about that being the time that a baby is most stable, was definitely true for our child. Her vitals were always the most stable, and she was always the most peaceful in skin to skin. And I'm sure it helped with breast milk production for me. It definitely helped with bonding. And we were so grateful that we were able to do skin to skin with her. even though we were told that we could only, visiting hours were 6 times a day, and we could only do skin to skin with her at 2 of those visiting times, we disregarded that, and we did skin to skin every time we visited our baby, as long as she was stable, and that was almost every visit. We were so grateful to incredibly kind sisters in the NICU. You can see a picture of the NICU. We were admitted at Garden City, and we were so grateful to some incredibly kind sisters. We went to visit them on our way out of the hospital. So you can see Emma all wrapped up, just saying bye to someone who really was a fairy godmother to her. I did feel I had to pick my battles though, and not everything was perfect. I'd given up so much in the pregnancy and in the delivery, and the one thing I was determined not to give up was exclusive breastfeeding. And so at one point I was struggling with milk production, and I wasn't producing the volume the pediatrician wanted her to be getting 3 hourly, and there was talk or suggestions that maybe she should get some top-up formula feeds, and I chose to fight that battle and said absolutely not. And the battle that I didn't choose to fight was the battle of bottles being used in the NICU. She initially, for the first 24 hours, she was what's called milk per mouth. So she just received fluid from a drip. And then after that, she slowly got feeds of express breast milk, but these feeds were given with a bottle. And I chose to rather fight the battle of express breast milk versus her not getting a bottle. And that hasn't been without its consequences. She has struggled a bit with breastfeeding, and we've seen some professionals, and she's now breastfeeding with a nipple shield. But my insistence on her only receiving breast milk has paid off, and besides some supplementation of vitamin D and iron, the only thing she receives orally is breast milk, and I'm really, really pleased that we've managed to achieve that. So as I mentioned, we were admitted at Garden City Hospital in Johannesburg. Garden City in the last few months has opened a kangaroo mother care unit. So babies who can't go home, but who can be discharged from ICU are admitted into this kangaroo mother care unit. And so pictured here is me holding her in kangaroo mother care with a special wrap made out of net care sheets and lined with cotton blankets. We were admitted there just for one night to try and establish, to get breastfeeding going, and for her vitals to be monitored. And I must say, being a doctor, I've worked in the public sector, and when I knew that I was going to have a preterm delivery, I was wishing that maybe I could spend some time in a public facility, because kangaroo mother care units are ubiquitous in public facilities, but not so in private. And I'm not sure where else in Joburg they exist, but I was privileged enough that my gynae delivered me at Garden City, and so we got to spend time in a kangaroo mother care unit. It was also lovely to spend time with other mothers who are admitted there long term while their babies gain weight and learn to breastfeed. And there were some babies who were classified as extremely premature, who were admitted there, who'd spent a long stint in ICU and were in KMC. And this was a really positive part of the experience. So there we are, pictured in the kangaroo mother care unit. My husband was allowed in to visit when the other mothers were comfortable with him doing so. And you can see it is still a hospital. There's a hospital bed and bassinets for the babies to be placed in when moms go to shower and when moms eat and things, and then babies go back into KMC when moms aren't busy. That was me packing up to leave. And just, yeah, you can see it's still a hospital, but it's much less monitored and much less noisy and light than in ICU. So now we are home and we are loving our baby. We are delighted that she is growing and that she's starting to interact with us more and that she's waking up. And yeah, we're just so overjoyed to be parents. So in summary, for our story, preparation was definitely key. I think that we prepared quite well, and we were lucky to have the warning shot and know that we needed to prepare for a likely preterm delivery. We were very lucky to make it to 35 weeks, but being prepared was key. Partners are also key. When I wasn't allowed to get out of my bed after my spinal for my Caesar, Graham could visit with Emma and could be with her and could bond with her, and he was such a support to me, and he was also caring for his newborn child, and whoever your partner is, if you have a premature infant, they are so key in the process. As I mentioned and explained, I had to pick my battles, and that will be different for each mom. I saw someone in the chat talking about the light. I also wanted to battle about that, but there's only so much energy you have when you're a new mom. A big thing is that kangaroo mother care is always possible. Don't be scared of the pipes. There are so many pipes and tubes that come off a baby who's being monitored in an intensive care setting, but that doesn't mean that those can't all be moved. The staff know how to move them. The staff bath the babies and do all sorts of other things, which mean that they have to work with those pipes and tubes all the time, and they know exactly how to get a baby onto your naked chest. And so KMC is always possible, even if a baby is being ventilated. Yeah, second to last is it's not easy. We were scared and we were tired, and it's easy to feel cheated out of your ideal vision of what the birth of your child will be, and that's normal and natural, and it is just hard to have a premature baby, and that needs acknowledging. And reach out for support. As Lynn mentioned, we do know each other personally. I reached out to her, and she was incredible at reaching out to me and checking in and being an amazing support. And there were other key people who we were able to just ask and chat to when we needed help. And yeah, this is not a journey that can be walked alone. I think Professor Libber also highlighted the importance of the whole family in this journey, and I would say that's really, really important. So yeah, thank you so much for listening to our story. Although we didn't have an extremely premature baby, we still went through a NICU admission and are glad to be on the other side of it. We are glad that we could KMC our baby, and that she is okay now, and we are so in love with her, and we hope for the best.
Wonderful. Thanks, Catherine. It's lovely to see that you've progressed and 7 weeks down the line being absolute star parents, and well done. And thanks for giving up your time. And I think Emma is, calling you to
Indeed. Thank you. Thanks so much, Lynn. Thanks for the opportunity to share.
Yeah, pleasure. Wonderful. Thank you. Okay, so let's just continue. I'm just going to flip through these pictures very, very quickly, and then Velma and I can sort out the question time, and you can ask all the questions you like. These posters and digital pamphlets are available for you to look at, to download, to utilize, about prematurity. What does that baby look like? Mimicking the womb environment in the NICU, looking at some tips for friends and families, and that's from Velma's book. Okay, let's just flip through that. We can go back if we want to. Whoops. The pamphlet, our premature baby journey, what the NICU's like, that womb environment, sound reduction, when does your prem baby go home, why should breast milk ideally be the milk of choice for your preterm infant, looking for premature assistance, okay, where to help, because breastfeeding just becomes so important. It becomes just top of the list of what you should be doing for your baby. It should be for every single baby, but it really is absolutely even more critical with these prem babies. On the expectantmothersguide.co's website, you can find lactation consultants, you can find those prem posters, prem pamphlets, our premature journey, little video clip, articles, there's breastfeeding info, there's skin to skin info. So please go and utilize all the information that you can while you're pregnant, so that you can really be well prepared. Velma also spoke about donor breast milk. It is absolutely critical that prem babies only have breast milk, and if you aren't able to express enough, there is donor breast milk available. There are people like Milk Matters, the Tembeletu, the South African Breast Milk Reserve, and they all deal with donor breast milk, which is really imperative for these prem babies. Velma has spoken about the littlesteps.co, the website, her book, Prematurity, Adjusting Your Dream, absolutely so important to actually be as prepared as possible. Okay, so I'm going to stop sharing, and please do ask any questions, write them in the chat box, and we will get Velma to answer them. Are you there, Velma? No? Aha.
I am. You just had to give me permission to unmute.
I was looking. I thought that's what must have happened. But you know, your name's right at the end of the list, you know.
That was the thing.
Yeah, no problem. Let's just have a okay, Kirsten asks, how easy is it to get the NICU staff to make these changes? As a mother, you usually do not have any authority to make these changes, such as nesting or lighting or reducing the noise. And these changes are wonderful, but in practice, is this done?
Okay, so I think when I started this work, I wasn't the most loved person by the NICU staff, because I did put this information in parents' hands, and parents did start asking the questions. So if this is how it works, and this is the physiology behind it, and so on, why is this unit not doing it? Because it's the best for my baby. So it is actually accessible to all parents. It is, like Catherine said, sometimes you need to decide which fights to fight. So it depends on which unit you are in. And I think that brings us to the point that it's important not only to choose your gynecologist, it's also important to choose where he is working. If he's working in a hospital that don't have a good neonatal ICU, then consider maybe going to another gynecologist who have a better ICU as backup, because yeah, it is important that you're at a place where you have good support. And you don't know what's going to happen. Anything can happen at last minute. We don't wish it for any parent, but it can happen. So I think that's something just to consider in your birth plan. Then do the smaller things, like one of those pictures that I've shown. If you can't turn off the bright lights in the unit, you can put like a little tent over your baby's head, so that your baby is shielded from that excessive light. But like we've seen in the pictures as well, Kangaroo Care actually does all of that for us. So if there's one battle you want to fight the kangaroo or the skin to skin care battle, because even if it's noisy, then you can put the baby's one ear on your chest and your hand on the other ear. And then immediately you have that quiet environment, similar to in the womb. They hear your heartbeat, they can actually hear the blood flowing and so on. So that's a good idea. Or you can also then play with a light. So the babies usually have a little hat. So all you can do, you just pull it over the baby's eyes. So there's these subtle things which you can do without turning around and making everybody very upset because you're this difficult parent. Just do the little things which you can do. But it is a real fight. I do agree. With my first one, I had a placenta previa. The placenta was lying in the wrong place. So I had to have a cesarean section in a private hospital. And I demanded skin to skin care in the cesarean section theater. And it was almost a war. But I had to get the support in place beforehand. And that specific gynae still do cesarean sections in that way that we've done it, and that girl of mine is now 13 years old. So maybe you pave the way for somebody else, that may be, but I think the important thing is stand your ground, decide which are the important things that you are willing to fight for, and be firm about that. Speak to your medical team and tell them, this is why I want this, how can you accommodate me?
And not only that, you've got all the information that both is available on Velma's website, as well as the posters that we've created together, and take that to the staff to show them that actually you really know what you're talking about. And thank you, this is the latest evidence, and thank you, this is what I'm going to be doing. And then it becomes very hard for them to say no, because actually they can see that this is what actually is the latest evidence.
Absolutely. And at the end of the day, if you're in a private hospital, yeah, the patient is king. I suppose I'm not allowed to say that. The hospitals won't be impressed. But at the end of the day, everybody wants what's best for mum and baby. So yes, if you have the information and you can back it up, then go into the discussion and stand your ground, because it's your maybe only pregnancy, maybe one of two or one of three pregnancies, but for the staff, it's what they do every day. And remember, sometimes we have staff that's not used to the ICU, so they feel uncomfortable with these suggestions because they haven't done it before. That happened. And sometimes you have staff that's been working there for 50 years, and 50 years ago, we did it totally different than we do it now. But also that go in with that softer way of doing. If somebody comes to you and they are aggressive, then you are aggressive as well. So start it in a soft way, bring the evidence, take my book, a lot of the information is in there, or just open the website. And if the doctors and the staff wants to go into a discussion and want more evidence, at any time, you're most welcome to send us an email, and I'm willing to help with information wherever we can. Sometimes it's a slow ship to turn, and some other areas people just grasp it on and understand the beauty of keeping a mum and baby together in any circumstances.
Okay, Marongwe is asking, are the doctors allowing the baby to sleep with a night dress that the mother previously slept with, since they are trying to minimize infections?
Yes, they actually are, or they should. If they don't do that, you can ask them to. And the reason is very simple. Whether you come in with whatever clothes you are wearing, or you come in with whatever you wore last night, it's the same difference. Because all that good bugs, your own bugs, the microbiome we call it, is in any way on your body and on your clothes and everything. And even if you have a little one at home, then the hospital often say, oh, you can't bring the little one in because infection. But you've probably just kissed your little girl and wiped the snotty nose and helped her to wipe her bum and everything, washed your hands, but all of that bacteria, your own home's bacteria, is on your body. So even if you come to hospital and they ask you to dress in new clothes, we provide you, which is absolutely not proven to lower the risk of infection in any way, that doesn't really help. You want your baby to be exposed to your own cultural bugs, if you want, to your own home bugs. So yeah, you can take it with, and the explanation, it's your microbiome. It's something that the baby was in any way used to while in the womb, and it's not going to increase the infection risk. But if they are afraid that it will, have a dedicated little blanket. So go and buy a receiver blanket and cut it in 3, wash it nicely, and sleep with it tonight, and tomorrow you take it to the hospital. That may just make them in their mind feel a bit better, because it's not clothes that you put with the baby, it's just a blanket. So it's just a mental thing.
Well said. I am the granny of a prem born yesterday at 34 weeks. Would this be for me too?
What, the putting the clothes with the baby?
I should imagine skin to skin,
Skin to skin.
type of thing.
Okay, so skin to skin is very personal. It's in your personal space, and you need to ask permission for it from the baby actually as well. So we prefer that skin to skin is done by mum and dad. But if you're also going to be a caregiver for the baby, or you're the granny and you have a good relationship with your children, and they would typically allow you to care for the baby and kiss the baby and do things like that, then you can also do skin to skin. Skin to skin's best place is for the mum to do, because of the hormones that changes in the mum. So if the mum does skin to skin, she can increase the temperature and can lower the baby's temperature, and it helps with breastfeeding and breast milk production and the microbiome and so on, which in a smaller amount can be done by dad, not so much by the grandparents. So if you're the granny, then you're welcome to keep your clothes on and just carry the baby. That's also very important, even when they're out of the ICU. So then you don't need to be in skin to skin, but you can still hold the baby and carry the baby around, most certainly. But that's a discussion you should have with the parents to feel where they're comfortable with those boundaries.
How important is mother's diet, excluding certain foods during breastfeeding the prem baby?
Not at all. So that is the old wives' tale, that you can only eat certain foods when you breastfeed, full term or preterm. If you do see you have a very colicky and crampy baby, then you keep a food diary for at least 18 hours, because there may be something that can actually then cause a little bit of crampiness. But anything you had in pregnancy, you could continue with in when the baby is born, because remember, the baby got used to what you taste and what you smelled. So if you had spicy food throughout your pregnancy, you can pretty much continue with that after birth. Just don't go double the amount. Then that can probably cause crampiness and irritation in the baby.
My baby was in the NICU for 4 weeks, and I wasn't made aware of any of this information by the NICU staff. I was also told I wasn't allowed to do skin to skin because of all the lines. Does the lack of mimicking a womb space and no skin to skin have a long-term effect on my baby?
It is the first choice if you can mimic the womb environment. If that was not there, your baby will know that you love her or him. And by just being there, that could already have been transmitted to the baby, if you want to put it that way. So as soon as you learn the information or are discharged from the hospital, then start doing skin to skin, do breastfeeding. If you were on bottle feeding, try and relactate so that you can breastfeed, even if it's only for a few weeks. Carry your baby very often, so you can re-establish those things, even if you didn't have it for whatever reason in the hospital environment. So don't feel guilty if you couldn't do it. It's out of your control, but do what you can do now, and just let your child know you love her.
it just breaks one's heart when you actually hear how wrongly informed these healthcare professionals are. And from our side, I mean, we try and educate these healthcare professionals all the time, and we do so much about it, but there are always some that are just, they've done it this way for however long they've been doing it, and nothing's going to change their mind, and it is drastically sad. Yeah, we're sorry that people actually have to go through these traumatic times. Maritza is also saying, I had a preemie and she was in the NICU for 16 days. It was so noisy, staff chatting, laughing. Why is it allowed if they know it should not be like that? And again, Maritza, I can just hear the anger, the hurt, all those emotions that are running through you. And I guess it's like every other occupation in life, is that they're good people, they're bad people, they're mediocre people, they're people who care and they're people who don't care. And yeah, again, I'm really sorry that you've had a bad experience, because it is so unnecessary. And people forget, they are in a work environment and they forget that actually this mom and this baby, it is a life-changing situation, and they just forget, and it's not the most important thing. If we could change it with this magic wand, I can promise you we certainly would.
Most certainly. And like I said, maybe we can change it for the next person having to go through that journey. But for you, when you are there, fight for the small wins. Do the little, the thief-like things, the things that nobody would really realize would actually do a good deal. What I also like to do is often, especially if it's people that's not convinced about developmental care and doing it the right way, then often they, in the medical fraternity, there may be this perception of baby shouldn't be breastfeeding because it's too much energy and they're too small for it. And if the baby is in skin to skin and they go to the breast by themselves and they suckle a little bit, there's nothing we can do about it. It's just the natural way that they do it. So if the baby just then perhaps land up on the chest and they do feed a bit, then yeah, it just happens. So make sure that the baby's in skin to skin. So don't fight the breastfeeding fight. Just make sure that the baby's in skin to skin, and breastfeeding may happen automatically. And yeah, unfortunately, these things happen because the staff are not necessarily synthesized. Or like I said, it's lone staff from other departments. They need to come and help out, and they may not be aware of actually how the premature baby work and what the physiology and the anatomy and the stuff behind it is. So it can also be ignorance. And then use your resources and inform them. Sometimes they actually enjoy to get the new information. Just depends on how you share it.
I'm just waiting for the winners to come through on my phone. So we will just go on to the next question while we wait for that. How do I know if my prem baby is getting enough breast milk, says Yoshine. She seems to be feeding very often.
Okay, great. If she's feeding very often, that's fantastic news. Remember, her tummy is smaller than her fist, especially that first few days. So she may only be taking 2 or 5 or maybe 10 mils at a time. And that are then absorbed, and breast milk is better absorbed than formula milk. And there's a lot of benefits to that. So preventing constipation and so on. So they absorb the milk a bit quicker, and therefore they need to feed more often. Now, remember, we said in the womb, they don't come with a clock. They don't drink amniotic fluid only every 3 hours. They drink it continuously. So they continue with that rhythm when they are born, and they're getting breast milk because how they get fed. So if they feed often, that's fantastic news. It may also be that your baby just want to have a bit of comfort. So just sucking on the nipple, because that is comforting the baby and helping with self-regulation. So you need to listen that you actually hear your baby swallow. It's that soft kind of sound. So you need to hear that. You must be able to see the ear and the throat moving. And then your baby must have 6 to 8 wet nappies per day. Then you know that they are getting enough milk, even if they're under ICU.
And we say thank you for joining us. Stay safe. Have a lovely evening.
Len, I see somebody is asking for a lactation consultant in Durban. Maybe for everybody that's on the call, make sure that you do get the mother's guide that Len also provide, because you have a lot of resources in there. And a lot of the people in your area is listed there. So that's a nice resource, or the app then, of course.
Good, thanks for answering that. That's great. Before the evening's finished, I will, or otherwise tomorrow, I'll email you some specific names as well. But yes, in the meantime, you can go to expectingmothersguide.coza and look under listings, and you'll find the lactation listings. Okay, Tama has put one in there. Claire Moffat is absolutely exceptionally great, and she's in Durban North. So yes, she's given you contact number. She's quicker off the mark typing than I am. So there you go. You should just check the info there, and you've got one straight away. Otherwise, Tammy has put the link in the chat box for the lactation consultants as well. Morongwe, you're asking if there are any bursaries for candidates who would like to become a lactation consultant. At the moment, I'm afraid there aren't, but do stay tuned and see what we will have available in the new year. Good, well, Velma, you've obviously done a really, really good job, and the questions have come to an end. And thank you so much for your time this evening. It really is great to have you here as always. And yeah, I just love the way that you and I are on the same wavelength, and it's just wonderful to have somebody who thinks the same, who's, you know, you're just passionate about these babies, skin to skin, breastfeeding. And like we've said before, that so often the professionals don't have that experience. They haven't seen the magical powers of skin to skin in the unit, and what can be done and achieved with it. And I think sometimes the moms don't realize that although they're professionals working in a NICU, they haven't been exposed to these things. And if you've seen it with your own eyes, it just becomes, oh, wow, I'm enlightened. And yes, the more that the moms also talk and pass on this information and say, hey, this is what I want to do, the more that the staff will be exposed to it and have their eyes opened as well.
Very true. Thanks, Lynn, and thanks once again for having me. I do appreciate, and I really hope that everybody on the call got something which they can use somewhere in their journey. And good luck with all the new babies, and may the mums have lots of sleep before and after the babies are born. Have a very good evening.
Yes, cheers, go well.
Bye-bye.